So the next presenter will be Dr. Ryan Lirette, MD, MPH. He's an LSU pain fellow. He'll be speaking on opioid withdrawal syndrome. Go ahead, Ryan.
Alrighty. Yeah, I'm Ryan Lirette. I'm one of the LSU pain fellows. I just wanted to talk about a case report I did that illustrates the need to recognize opiate withdrawal in ICU patients. A 37-year-old female was admitted to the hospital after a motor vehicle collision and sustained injuries requiring ICU stay. She had a history of opiate use and required large doses of fentanyl while intubated for 10 days. On extubation, her regimen was changed to small doses of hydromorphone intravenously. The ICU team thought this new opioid regimen was adequate to treat her pain. The day following extubation, she was noted to have restlessness, sweating, hot flashes, diarrhea, anxiety, and increased secretions. So just to get into some of the details of this, continuous infusions of opioid medications are frequently used in many intensive care units for the purpose of managing pain and inducing sedation. In addition, very large doses may facilitate mechanical ventilation and achieve pain control. This practice can lead to opioid tolerance and thus potential for opioid withdrawal. Risk factors include, but are not limited to, younger age, critical illness, and long duration of short-acting opioid defined as greater than 72 hours in an intravenous infusion. Withdrawal is a contributing factor for relapse and a key element of continued opioid use. During withdrawal, hyperexcitability of the nervous system occurs due to absence of opioid agonist. Symptoms include gastrointestinal discomfort, anxiety, insomnia, muscle cramps, and hyperhidrosis, and usually occur between 8 and 48 hours after the last opioid dose. Opiate withdrawal syndrome should be avoided due to patient discomfort, longer ICU stay, and more days on mechanical ventilation. Prevention strategies include understanding the patient's pain medication history, use of multimodal analgesia, acetaminophen, ketamine, neuropathic medications, etc., when appropriate, and non-pharmacologic interventions such as massage, music therapy, or relaxation techniques. Methadone and ketamine for their NMDA antagonist effects, though methadone has to be very highly dosed for this effect to occur, as well as clonidine and Precedex for their alpha-2 agonist effects, may decrease the time to wean from opioid medications. While there is no well-established method for weaning opioids, a recommendation from the American Pain Society is to decrease the daily infusion dose by 10% and to involve psychiatrists or addiction medicine specialists for prevention and treatment of opioid withdrawal syndrome. In one study of 10 patients in an adult burn unit, all patients who received benzodiazepine and opioid medications greater than 7 days developed acute withdrawal symptoms when the medication was withdrawn, with symptom severity related to the rate of drug weaning and not peak dose. So the patient mentioned earlier was experiencing opioid withdrawal symptoms. An IV PCA with hydromorphone was started at 60% of her previous morphine milliequivalent dosing while intubated. Her symptoms resolved and her pain was adequately controlled. In addition to Xanadine and celecoxib were also added, and acetaminophen was continued. So in conclusion, opioid withdrawal is an under-recognized diagnosis after intubation in patients in ICU. A recent systematic review commented that opioid withdrawal syndrome must be recognized and adequately managed. Although research to date is scant in adult patients in the ICU, understanding the subject further and implementing strategies to prevent withdrawal could help to prevent future issues with opioid use in the ICU patient population. So that's what I have.
Thank you, Ryan. Excellent topic, and I think something that always need to be on the guard for. One thing I have found in my experience is that opioid withdrawal, at least in the outpatient setting, whether you're talking oral or transdermal or even intrathecal, it's all over the place. I have had people have intrathecal pumps come out and catheter gets lodged, pumps allowed to run dry, and they end up in the ICU with delirium and severe withdrawal. And I've had people walk in 2 weeks later and say, yeah, my pain was a little worse. And so it seems to be very patient variable, even when the pharmacologics seem to be almost the exact same. I wonder if a topic worth considering would be uh, in the presence of other physiologic stress, such as this patient who's had some trauma. Does that make opioid withdrawal syndrome more likely or less likely? I think that would be an interesting question.
Mm-hmm. Yeah.
Having said that, I don't know if you have any thoughts on that, but it's something to maybe to chew on a little bit.